Hello, Feral and Ambulance Corps, and welcome back to episode 13. This time, we're going to be working on triage. So, why triage? In light of recent current events, such as the Baltimore Bridge collapse, mass casualty incidents are happening more and more, and so in some of these incidents, you're going to have more casualties than you can treat, and you're going to need to triage them. So, I thought we'd take a minute to review different triage algorithms. And so, without further ado, let's get into it. As usual, take a moment here to read the disclaimer. All right, so let's get into triage. So today what we're going to do is I'm just going to review what a mass casualty incident is, because that's when we're using triage. We're going to talk about principles of triage. I'm going to focus on two algorithms specifically, START and SALT, which are probably the two most common. And I'll go over with you guys the advantages and disadvantages of each one, and then you guys can make a decision about which one you would like to use at the Feral and Ambulance Corps. So what is a mass casualty incident? So an MCI, or mass casualty incident, is any situation in which the number of resources needed is greater than the resources available. Okay? It doesn't matter if you have 10 patients but you have 10 ambulances, well, then you have the resources you need. But if you have one ambulance and 10 patients, right, that's going to be an MCI. And in an MCI, you can't possibly see everyone and take care of everyone all at once, and so you're going to need to triage to set a certain priority order in who you're going to treat first, second, third, etc. Now, in any mass casualty incident, triage is one of the key critical actions that you're going to need to do, in addition to treatment and transport. And we're not going to focus as much on treatment transport during this talk. We're going to focus on step one of triage. Now, the basic underlying ethical principle of triage is that we want to do the greatest good for the greatest number of people. Okay, it's a utilitarian perspective, doing the greatest good for the greatest number. This is different from our normal operations where we're taking care of the person in front of us and trying to do the best we can for that individual. This is more trying to do the best we can for the most possible people, which means that some individuals might be marked, for example, as expectant, whereas on a normal day, you would do a full resuscitation such as CPR. Now, there are different triage frameworks. So triage happens every day in the emergency room. And that's typically what would fall under the banner of non-austere environment triage. So, for example, in an emergency room, when you come in, either by ambulance or just walking in, you're going to get triaged. And a typical system used in the emergency room is called the ESI system, where we'll rank people from 1 to 5 based on their anticipated resource needs. So just to put in perspective, 1 would be like cardiac arrest, and 5 is like minimally sick or minimally injured. And that determines the order in which we see people. But in a non-austere environment triage, everyone gets an attempt at resuscitation, including all critically ill patients. So we treat the sick people, the people who are the sickest, before those who are not that sick, and we attempt resuscitation on everyone. That happens every day in emergency departments around America. What does not happen every day is austere environment triage. This is the most common type of triage you guys have probably heard of. So this is the situation in which you're in an MCI and you need to prioritize treating the sick before the non-sick. However, in this situation, some patients who are the most sick, who are the most critically ill, who are unlikely to benefit at this point, are marked as expectant. And the different triage algorithms outline the criteria by which you would make someone expectant in a mass casualty incident. What expectant management means is you allow the disease process to take its course. Okay, so you don't intervene, you let things be. Now, the third category and the most extreme category is extreme environment triage. Now, this type of triage, to my knowledge, hasn't been done since World War II. But essentially, this is triage in the austere environment, but in reverse. So you treat the not sick patients first, the ones who are minimally wounded, so that they can become a responder or rescuer, either to accomplish the mission or help other sick people. So the example of that from World War II is penicillin was primarily given to patients with venereal disease rather than those with wound infections, because no matter what, the wound infection person is not going to return to battle. Whereas if you cured a sexually transmitted infection with penicillin, that soldier could get back in the fight. And so in extreme environment triage, you might prioritize treating the people who are not that sick first so that they can go back and fulfill a mission or other duty. And I really hope it never comes to that. Now, let's get into triage algorithms specifically. These algorithms are designed to help you assign priority and know who to treat first, second, third. So, Start Triage is shown, the algorithm is shown here. This system was developed by fire departments out in California. It's pretty common. It's pretty common around the United States, and so it's one of the most common triage systems out there. It's the one I learned while I was in EMT school originally. And it has some advantages, it has some disadvantages. So let's run through it. So the first thing you want to think of when you think of START is RPM. Okay, it stands for respirations, perfusion, and mental status. That's the order in which you're going to assess things. Then you need to remember the cutoffs, and that's where 32 can do comes in, because 30 is the respiratory rate, 2 is the cap refill time, and can do is the commands. Okay, so let's see how that might look. So you get to a scene of an MCI. The first thing you're going to say is, hey, if you can walk and you can talk, go to this location, right? That's going to screen out your walking wounded or your green triage category patients, okay? Right, so that's going to get us all of our greens right off the bat. Now the next step, you need to assess respirations. So are they breathing? If yes, then you're going to look, are they breathing over or under 30, right? If they're over 30, they're going to be red or immediate. If they're under 30, then you're going to go down to the P of perfusion, where you're going to look for a radial pulse. And if that's absent, or if the cap refill is greater than 2 seconds, that's also going to be immediate. Otherwise, if it's less than 2 seconds, then you're going to go to mental status, and you're going to see if they can follow simple commands or not. And if they can't, that's going to be red as well. Okay, if they can, then they'll be yellow and delayed. Now, notice at the top of the tree that if they're not breathing as part of Start Triage, you do reposition the airway. And if they're not breathing after that, they're going to be marked as expectant. Now here that's written as deceased. I prefer the term expectant because they may not be technically biologically dead at that point, but it means we're not going to do anything further there. We're going to, again, allow the natural disease to take its course. Now this does not mean you cannot provide palliative care to these patients. For example, they might benefit from pain medicine, which an ALS unit could give them, but they're not going to get further resuscitation here if they're in this category based purely on Start Triage, okay? Now, you'll see that the box is colored black. Sometimes this is referred to as being black tagged because the triage tags have the different colors. There's been a shift away from the use of the word black tag to avoid any racial connotation or confusion about that. So some people will just use the term expectant. That's the term I prefer because it describes exactly what it is. There's no ambiguity with expectant. Expectant management means you let things be and you let the disease take its course. Some people will also use the color gray to represent this now. So if you hear the term gray, that means the same as black. And it's just, again, to avoid any racial connotation or confusion. I personally prefer the term expectant, and that's what I teach. So that's what I'd recommend you use. Is the term expectant. Now, what are the advantages of Start Triage? So 1, it's fast. 2, the color coding allows you to easily visually recognize a patient's triage category. 3, it's entirely objective criteria. So it's numerical cutoffs, right? Over under 30, over under 2 seconds, can or cannot do. There's not that much room for clinical subjectivity, sometimes called clinical gestalt or gut feeling. There really isn't any of that in START. And proponents of START will say that that's an advantage because there is a psychological stress involved in triage. So for example, if you're using your clinical gestalt or your clinical, judgment to decide if someone should be expectant or not, you might feel like you're playing God and that you don't have the right to do that, and there can be some psychological distress that occurs with that. Whereas in START, because it's purely numerical, it's just numbers based. There's no thinking about it at all. It's just purely numbers. You don't have to think. You just apply the rule as it is, and that's it. Stick to the rule. So that's a potential advantage of START. Now, the disadvantages of START is one, it can only be used for adult patients. So for pediatrics, you need to use Jumpstart, which has a different set of cutoff criteria. The second disadvantage of START is that you have to remember numbers, which are hard to remember under stress. And so the mnemonic 32 can help you, but it's still hard to remember sometimes the number cutoffs, especially under stress, especially in an MCI. So that's another disadvantage of it. Now, some people also say the fact that there is no judgment and no clinical judgment is a disadvantage of it because START will fail for certain patients. I'll give you an easy example that I've seen is I've seen a patient who's been shot in the chest and they are walking and talking. In fact, they got shot and ran away from the scene where they were. Now, if you follow START as a START purist, you're going to put that gunshot to the chest, who probably has a popped lung and developed tension pneumothorax in the next 10 minutes or so, into walking wounded because they got up and walked away. They moved. But they're very quickly going to deteriorate. And so if you purely rely on START, you're going to get that one wrong. And so you have to remember that's a limitation or a disadvantage of START is it doesn't allow you to use your judgment as part of the algorithm. It also illustrates the point that triage is a dynamic process and you should constantly be reassessing. So those are the advantages and disadvantages of START. START's probably the most common one out there. Let's get into SALT next. So SALT triage is the other major triage system used in the United States. The origins of SALT, remember I told you that START was developed by fire departments in California. SALT was born out of committees of experts. So physicians from the National Association of EMS Physicians, which is an organization I'm a part of, as well as the Centers for Disease Control, defined something what they called the MUCC criteria, or Model Uniform Core Criteria. And those criteria were 24 criteria that outline what are the key characteristics of a triage system in an MCI. And SALT is a triage system born out of that. And I will say this, SALT is the only triage system that currently meets all 24 model uniform core criteria. Okay, so it is the only one that meets those criteria, and it was born out of a discussion of experts, right? People who are experts in this area. Now, how does SALT work? So the S stands for sort. So the first step is you're going to see, hey, if you can walk, come over here, move over there, just the same way you would in START. Those people you're going to assess last. Then you'll ask, hey, if you can hear me, wave, and you'll see who can make a purposeful movement and can show a wave. And then you're going to see who doesn't move at all, and those are the patients you're going to assess first. Now the A part stands for assess, so that's the second step here. And the L part stands for life-saving interventions. So this is a difference with START in that life-saving interventions are baked into the SALT triage algorithm. And those life-saving interventions include controlling major hemorrhage with tourniquets, opening the airway, rescue breaths if child, and chest needle decompression. Okay? Once you've done that, then the T stands for treat and transport. Okay? So you're going to assess, and then this part of the algorithm shows how you do the assessment. So first step, just like in START, breathing or not. In this case, if you're not breathing, again, they use dead here. I'm going to say expectant is what I would encourage you to use. Now, you'll notice they say expectant down here. I'm going to use those interchangeably, okay? Because you're not checking a pulse, so I don't think you can say technically dead here. You can just say apneic, meaning not breathing, but it's irrelevant, okay? You're going to mark that person as expectant if they're not breathing. Now, if they are breathing, then you're going to see, are they obeying commands? Notice that overlaps with START, which checks for can by follow commands. Do they have a peripheral pulse? Again, overlaps with START. Are they in respiratory distress? This is sort of overlaps with START, except START makes you assess the respiratory rate specifically. And then is hemorrhage controlled? This isn't explicitly mentioned in START, but that's an important thing for SALT. Now, if the answer is yes to all these and they only have minor injuries, then they're going to be green. If they don't have minor injuries, then they're going to be yellow. Now, you might be asking, well, what is a minor injury? That's where clinical gestalt and clinical judgment comes in. So SALT is more subjective in this sense, in that you can use your own judgment. Similarly, if the answer to any of these questions was no, Then you ask yourself, is this patient likely to survive given the current resources? If no, you mark expectant. If yes, then they're immediate. Now, again, this is subjective to a certain extent. It relies on clinical gestalt. And remember, at NMSP, it's EMS physicians and the CDC. A lot of doctors made this, and a lot of physicians are more comfortable using their clinical gestalt. Now, a lot of paramedics and EMS providers are as well. But some, just in my anecdotal experience, some EMS providers are more comfortable with the numerical aspect of START because they don't have to put their judgment or their impression. So let's review the advantages of SALT and the disadvantages. So advantages, it's based on the best available scientific evidence, was developed by a panel of experts, and it's the only system that meets all the model uniform criteria. Okay? Now, other advantages of SALT. Is it fast? Yes. Is it color-coded? Yes. Can you do the color-coded tags for visualization? Yes. Does it allow you to use clinical judgment so you don't mistriage that patient who got shot in the chest and run away? Yes. And so you can potentially get more accurate that way. Disadvantage of SALT is you have to use some clinical judgment, which can be, again, psychologically uncomfortable, or people may feel they're not experienced enough to do that. I would say my personal preference is I prefer SALT for this reason, but that's because I feel comfortable as a physician who's boarded in emergency medicine and in EMS to make these decisions. But other people might not feel that way, and I know that people are split on this. So it's important that you understand the disadvantages and advantages and decide what's best for your ambulance corps. I will say it's probably best to be standardized that everyone in the ambulance corps does it the same way. And so that's a really important thing to do. Now, let me talk a little bit more about the model uniform core criteria, just so you know what I'm talking about. So I mentioned that SALT is the only system that meets this. Again, this was born out of NMSP and the CDC work group panel of experts. And just to give you a sense, I'm going to include a link in the description to this full document where you can look at all of Appendix B and see all the criteria. But these are the types of criteria that are there. And so you might ask, well, if SALT meets all the criteria, why does START fail? So one, right off the bat, START fails immediately because one of the criteria is triage systems must apply to all ages and populations, and START can only be applied to adults. SALT can be same algorithm, adult and kids. You don't need to remember a second one. Okay, that's another advantage of it, right? And then some of these other ones, triage systems must be accessible across a broad range of incidents. They must be simple, easy to remember, and amenable to quick memory aids. They must be easy to apply in practical and austere environment, right? You can go through this entire list. I don't think it's worth us going through all of it right now. Just know that this is out there, and this is the best available scientific evidence we have here. Now, I will say we don't have, while I say it's the best available evidence, we don't have a great amount of scientific literature backing one triage algorithm or another. And I will say the scientific literature doesn't clearly demonstrate the superiority of one triage system over another. To the best of my knowledge, no study has ever definitively said, yep, we should definitely be doing this one. But if you want the most evidence-based and the most scientifically supported, SALT is going to be the way for you to go. That doesn't mean it's in real world trials is necessarily better, but it just means, well, it's the best we got right now. And so just know that information, just something you should be aware of. And it's on, the core can decide which way it wants to go. But now you have a little bit more information about two major triage systems. So just to summarize that up, there's no really universally accepted triage system based on the scientific literature. START and SALT are probably the two most popular. And again, SALT is the one that was the only one that meets all the MUCC criteria and was based on the best available evidence from those work groups. So hopefully you found this helpful, increase your knowledge a little bit about triage, and I look forward to talking to you guys on the next one. I'll put some links in the description down below, some references where you can look at more information about START and SALT and where they come from. All right. Take care, guys.